This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
Can use this. All right. Well, it's wonderful to be here because I was just saying to Peter and I was speaking this morning about how many years ago it was where we were sort of planning what a great thing it might be to get orthopaedic surgery and general practice together, and what a sort of fantastic opportunity to make a difference in the care of people with osteoarthritis. And at the time, I was sort of thinking, well, I do mostly mental health research in primary care, and whilst I've got a lot of interest in multimorbidity, I hadn't really seen the overlap with osteoarthritis that really does exist, and I hope that this morning I can take you through some things that will show how they go together. So, osteoarthritis is, as we know, one of the commonest problems in general practice, and the other thing that it's very tied up with is other conditions. And so from the GP perspective, when we see people every day in the clinic, we see people with co-occurring physical and mental health problems. And, depending on, I suppose, the person in front of us, one or other of those conditions will come to the fore. And it's very interesting how people that present to the community and present to their GPs often come with a particular lens, and they might tend to bring their physical health problems. Other people tend to bring their mental health problems. And yet, when we think about them, they're actually maybe all the same population. And that's been something that's really interested me for a very long time. How can we organise primary care so that we're better dealing with the challenges that people face? The top 3 non-communicable conditions diagnosed in general practice, according to our latest sort of data, are hypertension, depression and arthritis. So, as Bronwyn said, or Peter, Michelle, I think it was, that 2.6% of all GP encounters are for arthritis. Now, that actually is, and that mightn't sound a lot in terms of GP consultations to have anything, 2.6% doesn't sound much, but anything over 1% makes something extraordinarily common. And you can see that 2.6% of encounters puts osteoarthritis in the top 3 conditions. So it's very, very common. And we know that of people that present with osteoarthritis in the community, that 4 out of 5 of them are going to have at least one other long-term condition. And, what does that mean? It means for them often that they're in constant pain. It's one of the biggest challenges that people focus. And they often retire early from their work. They're often unable to work, and as we know, they tend to have a much higher chance of requiring or using regular opioid medication and other very, very strong and complicated analgesics. They're also about 3 times more likely to report or self-report poor health, and I'll come back to that in a moment. And they're also likely to have psychological distress. So they're a very complex mixture of symptoms that present in the community. So I want to introduce you to Jim. Now Jim is a real person, not called Jim, it's not his real name, but we've been doing a large study with the federal government, funded through the Department of Health, and that's been rolling out through practices in Victoria, New South Wales and Queensland, and has involved some of the primary health networks. And that's been focused on mental health. So we've been identifying, using the clinical prediction tool that we've developed, people with complex problems and triaging them to give them the opportunity of working with a care navigator to try and sort out better care. Now, Jim is pretty typical of the people that we've recruited into the complex area or the complex triage group of this Link Me trial. So he separated from his wife 18 years ago, but he's unable to be financially independent and he still has to live in the house with her, and he pays her a little bit of rent. He has multiple chronic conditions, including arthritis, and he recently had knee surgery. He had from a serious car accident that he had many, many years ago. He's on a disability support pension and he lives fortnight to fortnight in terms of money. He reports significant alcohol intake and he has a problem that his GP is aware of, and he's felt very hopeless for many years because he has no money, no job, no food and no home of his own. They're the notes that the care navigator took the first time that she met Jim, and I'll come back to him later on, but it was quite amazing that the presentation I gave recently about mental health, we focused on Jim, and yet, you know, one of the big things that Jim had was osteoarthritis. That was the reason that he often came to the GP and that he kept in contact with the GP. He wasn't coming for other reasons. So one of the things that I'd want to put to you is that whilst from a specialty lens, we obviously need you to come with your full force of specialty knowledge to bring to the conditions that people like Jim have. One of the things that I think we could do much better as a healthcare system is start to see that people actually, in general, have multiple chronic problems. And it's actually the rare example that comes simply for a knee or hip replacement and has nothing else going on. I mean, they exist, obviously, and when they do, isn't that great? Because they do really well and off they go. But most people are not like that. And so one of the things that we've focused on through our general practice research is really looking at intervention points where you can get to multiple conditions and address them through pretty targeted approaches without having to go through an enormous amount of assessment and healthcare resource use, and to see how that gets us. So to focus on things like physical activity, nutrition, reducing people's alcohol and drug intake, and trying to get them to take part in self-care strategies. Now, we think, if we could do that with people, and we could get them to structured interventions where they really got the sort of key ingredients of the interventions that we know make a difference, if we could actually get those things to match up, then wouldn't that be a wonderful thing? And we should anticipate that people would have better health outcomes. But we know in the reality of the way our healthcare system is organised that that often doesn't happen. And that fascinates me. Why doesn't it happen? I think in Australia we actually are not in shortage of healthcare professionals or healthcare interventions. We're actually really we're surrounded by those. Now, people don't always get access to the right kind of treatment, but we get access to an enormous amount of care as Australians. And the thing that I think that we've got at the moment is that we haven't got good allocation of the right kind of treatment to the right person at the right time. They've actually got plenty of treatment, however, and so it's a matter of shifting the way that resources are allocated and really getting more sophisticated in the way we identify people. So this is some work from a number of years ago now, but it really hasn't altered, and it's looking at from about 7,500 people in primary care across 30 general practices in Victoria. These were the sorts of problems that people self-reported. And, you know, top of the pops, back problems and arthritis. Then we look all the way down, they're the common conditions. They are the top conditions that are seen in primary care in Australia, and they remain so. And if we went out today these are the non-communicable common problems, we would find a similar sort of list. Now, the reason that I've popped that up there is that if you look along, what we've done there is to look at the number of people with back problems, arthritis, etc., and then how many of them are scoring as maybe having a probable depressive disorder. And you see that it varies from about 1 in 4 up until 1 in 3. But it doesn't really vary enormously by condition. So you'll see, I mean, people are often surprised by cancer being, 26.2 down the less likely, but that's the interesting thing. I think in cancer care we've probably done a better job of actually addressing people's full needs, and therefore often a cancer diagnosis, people go through a lot of reflection and thought about their mental health as well. And so it's interesting that we see that, and we've seen that in many surveys in primary care. So one of the things that this is showing is that there's very strong dose-response relationship between the number of physical health conditions that a person has and their mental health. And it doesn't really matter what those physical health conditions are. The more they have, the more likely they are to have depression. And that's something that we published a number of years ago now, and we're still sort of trying to work out how do we deal with that. So one of the approaches that we've taken, and this is where I think we aligned with the discussions having with Peter about the CRE, is that we saw so many parallels with what we were doing in this depression space with what he was doing in the arthritis space. And this was all about trying to develop a very simple checklist or simple survey that patients could do while they were waiting to see the GP or after they'd seen the GP, something that was very, very simple, less than a couple of minutes, but could actually have good predictive power about the people who are going to have challenges down the track, the people like Jim. How could we find the Jims? And maybe he's a sort of obvious Jim, but there's Jims that aren't quite so obvious. How do we find them when often they sit in waiting rooms, they present very well to primary care providers, they don't tell them all about the difficulties in their lives? And how do we find them in an easy way without asking those people a lot of intrusive questions or putting them through a battery of tests that might take half an hour or whatever? So that's what we've been working on, a really practical, simple sorting thing. I often relate it to sort of doing the washing, which is what all of you would be doing on a Saturday morning if you weren't sitting here. But, you know, when you're getting it into the piles and you're not really, it's not like you're getting it into the fine-grained, putting the silks with the sort of finely coloured things. You're just trying to put delicates and whites and, you know, things you can just shove in any old load. Really a simple sorting process that works in primary care so that we can just try and use that time very efficiently. And so we've developed it along with a model underlying it that is thinking about how do we assess with a decision support tool that's engaging and that gives people some reporting back. Because I won't dwell on how we developed all of this, but it's been developed over many years. It's had focus groups, a lot of consumer input, patient input, etc. And one of the things was people wanted some quick self-report. They don't want a whole lot, they just want something back. They don't want a lot of risk assessment either. They just want a little bit of reporting back about their symptoms. And so we've developed that with feedback. They want to be able to reflect, prioritise, and we wanted to try and motivate them. So we've worked with a psychologist who's expert in motivational interviewing to try and put into this little tool the magic ingredients of motivational interviewing. And then they're triage and tailored management. And in the big national trial, we're sorting them only into two groups, low complexity or high complexity. And we're hoping that they're going to get symptom improvement and cost effectiveness at the other end. Well, people like Tony Scott can work that out. The high complexity group get access to a care navigator, a little bit of extra money where they can go off and get some extra support if they need it, and a tailored management plan and a bit of coaching over 8 sessions. So they fill it in the waiting room. This is sort of an earlier version of what it looks like, and it includes our risk stratification tool. It provides them with a bit of feedback, and it's really designed for easy use. We're testing it in the waiting room because we want to get large numbers, because we're doing a randomised trial and we want to be able to show whether it's effective or not. But when it is out in real life, we don't expect that it would have to be used in the waiting room. We just want it to be quick and easy to use. One of the things that we found is that people want to a bit of a mixture of words and sort of iconography, and we use very, very simple. The more we did work with people who are going to use it, the simpler and simpler and simpler this got, until it almost looked like it was hardly anything at all, which is just amazing, because we started off with lots of whiz-bang diagrams. And we just simply say to people, from what you've told us, things seem to be difficult in these areas right now. And we say, well, you know, there are a few different things you seem to be having issues with, but no one can do everything at once. Why not pick 1 or 2 priority areas to focus on first, And once you feel like these areas of your life are more in control, you can choose something else. Which two of these do you think have the most significant impact on your life? And then they get to choose whichever ones they want to focus on. How important is it to you, and how confident are you? The sort of motivational interviewing questions. And then out of that, amazingly, they go through a few more screens, and then the people who are in the severe and complex area, like that person would have been, then are given the opportunity to work with what we called a Target D nurse, or a care navigator is what we're calling them now in the newer Link Me study. And we're actually looking at them, looking at the model as a model that we could train easily the nurses that already work in the primary care practices around Australia, so that we made sure that it was a very easy training process. It's mostly done via the way that the iPad and the tool works, and any trained nurse who's had a bit of experience with patients works brilliantly with this. They just get it. They know how to kind of take whatever it is and go to the next step, and they're very good at arranging care for people. So just to finish up with Jim. So what happened with Jim? Well, it was this one, and he's not the only person that this story is very relevant to. There are many, many examples of this. The care navigator that worked with him, she was a primary care nurse. So she had her first session, which lasted about 20 to 30 minutes with Jim, and all of that information that we showed at the beginning came out. One of the first things that she did was organise him a food hamper, which was, I don't think would have happened if we didn't have this sort of study going on. And then she spoke to him. She also realised that he's had completely lost touch. Even though he's living in his ex-wife's house, he had completely fallen out with all of the children, and the wife was just tolerating him because I think she felt extraordinarily sorry for the situation he was in. And so he would come and go from that room at the back of the house, not seeing them or anything. Daughters wouldn't speak to him. And he was really very, very close, actually, to thinking that he would just commit suicide, turned out. Not that he answered the questions in that way as severely on the tool, which was interesting as well. He then declared his severe alcohol problem. It wasn't as obvious, she said, the nurse who presented this. Once he said it, she thought, oh yes, it all makes sense. Of course, this is what is underlying all of it. And she spoke to him about maybe getting into detox. And then she followed up and found a few places where he could go. And lo and behold, and I think she was just a very down-to-earth, caring person, to be honest. And she showed him a few options, and he went off to detox. And she also arranged some funding for him to have a bit of hydrotherapy, because his knee replacement, hadn't gone that well, and he was having ongoing pain. He wasn't getting much support for that. Now, the interesting thing was the GP that he'd seen for about 20 years had gone on leave. He'd had 6 weeks of sabbatical, and off he'd gone. And the nurse had sort of mentioned something about Jim to him before he went. And I think he thought, oh, good luck with Jim, we've seen Jim a long time. When he came back 6 weeks later, there was Jim. And Jim was more hopeful about life, and he had a list of things he wanted to achieve when the GP saw him, which is what the nurse had told him to do, and it was exercise, cooking, joining the local men's support group. Well, the GP just came out to the care navigator and said, I do not know what you've done with Jim, but it's just brilliant, and I love this, can you stay in our practice forever? So it is obviously not every example is going to be that amazing, but Jim's life is back on track, and he's doing much better. So I think he's gone from someone that might be a failed knee replacement therapy patient to someone who's actually starting to have their life sorted out. Of course, it's going to be a bumpy road for Jim. I'm sure it's not going to be an easy road, but I think that hopefully we can work together to make that kind of experience more the norm, because we have all those elements within our healthcare system. We're just not getting to them, to the people, in the right way, at the right time. And it's very exciting to be involved in work that's just chipping away at trying to do this better and better and simpler, do it more simply in a cost-effective way and try and help people just live more fulfilling lives. So that is me. Thank you.
We do have time for some comments or questions. So, Jane, I'll allow you to lead that.
Sure.
But,
any questions? Yes. Do we have a roving mic? Oh, we do. Oh, we've got them there. Yes.
Hi, thank you for that. That was really interesting. I was just wondering, with the navigated care with the nurses, where are they getting the funding to help fund hydrotherapy classes or providing food, packed hampers and things like that?
Yeah, well, we're calling their care packages. So it's a trial funded by the federal government. One of the things that we've been funded, it was awarded a competitive tender, was that they're interested in thinking about how, after the MBS review, that there may actually be some change to the way that the mental health care items are funded. And of course, we've used a lot of mental health care item numbers with mental health care plans, treatment plans, chronic disease management plans, team care arrangements, all of those things. If you're familiar with those, they're very common items used in general practice. And the federal government is looking at new models of funding. And I think, there's a budget this week and there's a few things been leaked already, and some of these are around registration and assessment, different sorts of care packages. So this model, the findings from that study, we're taking directly to Cabinet actually, because they're very interested in whether or not we could have some funding at a local level that was administered for people that might require little extra bits of funding. And for the first time ever, this is the first ever for the federal government to do this, firstly to do a randomised trial, secondly to allow out of the care package funding to say that there could be things that were not necessarily mental health care, but would be evidence-based treatments that might help people's mental health, was how we worded it. And interestingly, people had access to the care packages, but we also said to the nurses, that's only for when you cannot get it out of the healthcare system. And so most of them took it as their challenge to get it out of the healthcare system and not use the care package. So it's a trial. If it goes forward, it will be federal government funding, probably via PHNs, the local GPs would have to apply to use some of that package for each individual patient. I mean, it's possible it might go direct to practices, possibly. I don't know. That's a really interesting, there's a very interesting health economic issue. Does that answer your question? Yep.
Jane, do you think this could be a forerunner for helping with other chronic diseases like arthritis, for example, where a lot of it is in-hospital-based care, and then the reliance on non-surgical care is actually a burden on community provision, which is federally funded? Can you see this leading the way? Is there an intention?
I think so, Peter. I think there's a lot of interest in this federally, and they're just trying it in this area to see, how it goes. I think there's a lot of nervousness though, because we've got the NDIS, which is very expensive, and still rolling out. So the idea of then, although there's also a lot of worry about the people who miss out on the NDIS, but there's an acknowledgement that people aren't getting the right packages of care, but there's also a fear that if we just gave people access to a couple of $1,000s or whatever it is per complex case, that suddenly we'd have, millions of complex cases, which is what happened with mental health treatment plans. We've got millions of mental health treatment plans. So there's a lot of anxiety around how much would it really cost. The principle of it, I think people really like, and there's also a lot of interest in now this cross the sectors of government, across social services and health, and they see this as an example of this cross-sectoral collaboration or, funding. I think they're testing. I think they're very interested in these new models.